Okay, so let's continue from where we left off. So we are now on the discussion on the procedure of direct microscopy for spirochetes detection. So for the procedure, again, direct detection is usually preferred when a lesion is present, primarily in cases of primary syphilis and secondary syphilis. So please take note that even though there are lesions in tertiary syphilis such as yun ngang gammas, we do not use the lesion because it already contains dead organisms, so it is not to be used for direct microscopy or indirect microscopy. So for the procedure, first we need to clean the lesion with clean water. So what is the purpose of cleaning the lesion with clean water? So this is to eradicate the presence of the normal flora so that they will not cause any discrepancy in the detection for syphilis. So please take note that we should not use soap or antiseptic when cleaning the surface of the lesion. So even in regular, for example, regular gram stain or regular KOH, usually it's KOH. When we do KOH, we scrape the skin. So upon scraping, we usually ask our patient if naligo ba sila. Tapos you can really feel the surface of the skin if a lotion has been applied prior to sample collection. So if a lotion is applied, we should always ask our patients to clean the area to get rid of the lotion that has been applied on the surface of the skin. And yun nga, cleaning should not be soap or antiseptic should not be involved in the cleaning of the skin surface. So second, after doing so, we need to gently abrade. So for example, if this is the skin and here is the lesion, then we should gently abrade. So like causing a small minor laceration. So lacerate the area. We can use scalpel. Do not use blade. It's hard to control blade. So konti lang, gently abrade. Wag naman yung parang ganon talaga. Konti lang naman. Gently abrade the area or the lesion. And then after doing so, we need to apply pressure. So as to express out the serous exudate. Okay, so we need to gently apply pressure so as to express out exudate. So, diba, exudate and transudate, if a serous fluid accumulation is caused by anything but, if it's caused by anything but inflammation, then that is transudate. But if it is a result of an inflammation, then automatically that is an exudate. So, in your AUBF, when you say transudate, it's usually clear. As for an exudate, it's usually cloudy. And also in exudate, there's presence of more WBCs and bacteria compared to transudate. And then next would be to place a drop of the exudate on a slide. Then place a cover slip and then examine. So yun nga, based on Henry's 21st edition, we should observe white treponemes. White treponemes against a black or dark background. Okay, so take note that bright field microscopy should not be used. Why? Because it cannot be used because the organism has a very narrow width. Because the organism has a very narrow width. Because of this, dark field microscopy is implied. Why? Because the condenser allows the light to hit the treponemes in an oblique angle. Because of this, even though the treponemes have a very narrow width, because the light has been applied in an oblique angle, it can actually initiate visualization of the organism against a dark or black background. Okay, so direct microscopy is actually positive several weeks before a positive serological test. Before a positive serological test. And the sensitivity of dark field microscopy is around 80%. So it has a very good sensitivity. One thing that we should remember when collecting specimen or lesion exudates for direct microscopy is that we should not collect from the mouth. Why? Because there might be contamination with commensal treponemes. So the reason behind is contamination with commensal treponemes. So we have commensal treponemes. So these are treponemes that are part of our normal flora. So examples are for example, we have commensals of the genitals. So we have, where's my red ball pen? Treponema phagedensis. So example, we have Treponema phagedensis. So spelling PH, phagedensis. We also have Treponema refringens. And mas pa itong isa, Treponema phagedensis minutum. So these are some of the commensals of our body, and this can be found particularly on the genitals. So if we are to collect these samples, we might actually mistakenly identify them. So can be mistakenly identified as T. pallidum. T. pallidum. So you might ask, Ma'am, why, how can they be mistaken as T. pallidum? Because when you say treponema, diba, the difference between treponema, borrelia, and leptospira are actually their morphology. And if you are to use direct microscopy, we cannot really identify the organisms up or as low as to their species level. So we can only identify them based on their genera. So either borrelia, leptospira, or treponema, but we cannot really identify as to the as specific as the species level. So if to get rid of the commensals of the genitals, we have actually a remedy. So the remedy is actually just to carefully clean the area before collection. So we just have to carefully clean the area before collection. So just take note that when cleaning the area around the lesion, we should not use any soap or antiseptic, because they can also be harmful, or they can cause, they can be toxic rather to our T. pallidum, which are the actual organisms of interest in direct microscopy. So by this, we are done with direct microscopy. So let us now proceed with the serologic tests in the laboratory diagnosis of syphilis. Okay, so serologic test. So serologic test for syphilis is actually more concerned with the detection of antibodies. Treponemal antibodies. Treponemal antibodies. Or treponemal or sometimes non-treponemal antibodies. Okay, so in the serologic test for syphilis, there are actually two antibodies produced by the infected individual. So there are two types of antibodies. So two antibodies produced by the infected individual. So first we have the so-called non-treponemal. First we have the non-treponemal antibody. So when you say non-treponemal antibody, it actually pertains to our reagent. So reagent, I cannot really say that it is an antibody because the book of I'm not sure if it's the book of Bryant or the book of Henry's. It was stated that reagent is a substance with an antibody-like property. So it has an antibody-like property in a sense that it binds with colloidal suspension. Colloidal suspension of lipoids extracted from animal tissue. So the most commonly used animal tissue for the detection of reagent is actually your beef heart. So commonly beef heart. So the beef heart contains a specific lipid sequence that causes a sense or that initiates sensitization with your reagent. So same goes with the human body. So the heart actually contains that particular lipid component that might induce sensitization with your reagent. That is why we label reagent or we categorize reagent as a non-treponemal antibody. So why do we need to detect reagent if it can be stimulated or if it can be sensitized by substances other than the syphilis substance? It is because reagent is actually produced or there is an markedly increased in the concentration of reagent in cases of syphilis infection. So take note the reason why we detect for the presence of syphilis or why the reason why we test for reagent is because reagent is markedly increased in cases of syphilis. So yun nga, based on this we can say that reagent reacts with lipid antigens that are closely associated with your syphilis. We call that antigen cardiolipin or your Wassermann antigen. This is the reason why we sometimes refer to our reagent as the Wassermann antibody. So the second antibody would be your treponemal antibody. No more space. The second would be your treponemal antibody. Okay, so the treponemal antibody reacts with T pallidum. So it reacts with T pallidum and closely related strains. Okay, so the treponemal antibodies react with T. pallidum in general, not just T. pallidum, subspecies pallidum. So it can also react with a subspecies other than, with a different subspecies other than your T. pallidum, subspecies pallidum. So yun nga, the causative agent of Yos, Begel, and Pinta. Okay, so for the syphilis antibodies, in primary syphilis, the predominant antibodies are actually your IgG and IgA. In secondary syphilis, you can observe markedly increased concentrations of your IgG. In early or untreated early latent syphilis, the predominant antibody would be IgM. And as for untreated syphilis, the predominant antibody is a non-specific IgA. Okay, so these are the antibodies and their specifications based on syphilis infection. So, for the non-treponemal serologic test, so for when we say non-treponemal, we detect for the presence of your reagent. Okay, so this test is based on flocculation, the principle called flocculation. So flocculation is actually precipitation involving fine particles. So if the particles or the carriers used are finer or smaller compared to those used in precipitation, then we call the procedure as a flocculation procedure, or we call the method as flocculation. So the non-treponemal antibody, which is your reagent, is actually produced 1 to 4 weeks after the appearance of the primary chancre. So, hindi porkat may chancre na, we can now use VRDL and RPR for the detection of reagents. So, yun nga, please this is actually the reason why direct microscopy is the preferred method in cases of early syphilis, such as primary syphilis and secondary syphilis, because it would take time before our body would react to the presence of the syphilis. So, it would take time for them to produce increased concentrations of antibodies that would allow us detect them in vitro. Okay, so please take note that the serum that should be used for the detection of non-treponemal antibodies should have inactivated complement components. So based on this, we can say that we should use a heated serum. So please, if you can remember, heating is one of the methods in inactivating complement. So, just for review purposes, inactivation of complement happens when we heat our serum at 56 degrees Celsius for 30 minutes. Now, if we were not able to perform the test within 4 hours, so if the test was not performed within 4 hours, then we need to inactivate the complement. So we need to perform reinactivation. So how do we do that? So we need to reheat again, or we need to reheat our serum at 56 degrees Celsius for 10 minutes. And then cool down at room temperature, then perform the test. So 30 minutes to 1 hour would be enough to cool down our serum sample to room temperature. So after that, we can now perform non-treponemal serological tests. Okay, so first we have the VDRL, or your venereal disease research laboratory. So please take note that venereal is actually, it simply means STIs. So it's a term referring to STIs. When we say venereal, this refers to diseases transmitted through sexual activities or sexual intercourse. So for the VDRL, it has the advantage of being both a qualitative and a quantitative slide flocculation test. And aside from serum, it can also use spinal fluid as a sample. So for VDRL serum, remember that when performing qualitative tests, upon the addition of serum, and after that we add our reagent, then we mix them together, and then we perform rotation for a number of minutes, and after that we should observe for the presence of any flocculation. So for VRDL serum, the rotation would be 180 RPM, and it should be rotated for 4 minutes. As for your VRDL CSF, it should be rotated at 180 RPM for 8 minutes. Okay, so let's have a brief discussion, or let's have a general idea on how VRDL qualitative serum test is performed. Okay, paper. Okay, so for VRDL serum slide test qualitative. So VRDL serum slide test. Qualitative, so this is the procedure. So it's very vital, or not very vital, but it is important to know the procedures in the performance of the different laboratory tests, because during the board exam, they might actually ask like, what is the solute being used in this particular method, what is the solvent, what is the reacting agent, and what's the expected result. So by knowing the procedure, there's no need to memorize all of those things. You just have to be familiarized with the procedure, and you will now have an idea on what the answer would be to those kind of questions. So just imagine that this is a slide. So the slide should be paraffin ringed or ceramic ringed. So we cannot just use any slide, but I think in the laboratory we use any slide available. But there are some VRDL kits that you know, they would give you a particular slide, like yung black na slide na may 6 oval squares, black, tapos diba we just wash them with running water, which is actually not the method for washing of those plates. But yun nga, like what I said, different medtechs, they have their own procedures on how they do things. Anyways, we need to pipette 0.5 ml of heated serum. So this is around 500 UL. Then after that, we need to add 1 drop. That's 1/60 ml. So we need to use the specified or the special pipette for VRDL testing. So later we will know about the different specifications and characteristics of those pipettes. So 1 drop of the antigen suspension, using an 18 gauge needle. Then rotate at 180 RPM for 4 minutes. If it is a CSF, then it should be rotate at 180 RPM for 8 minutes. So for the rotation, please take note that we should use a mechanical rotator, hindi human hand rotator. So we should have a mechanical rotator that it should describe a 3/4 inch diameter circle at 180 RPM. So in every rotation, for example, if this is the circle, in every rotation it should cover 3/4, it should cover an 3/4 inch diameter of the circle to allow homogeneous distribution or homogeneous distribution of the solution, so as to initiate equal sensitization or maximum sensitization between the antigen and the antibody on our serum. Then after that, after 4 minutes, then we should read for any signs of flocculation under LPO. So flocculation should appear as short rod forms. We should observe short rod forms of flocculates under the microscope. Okay, so that is the general procedure for the performance of qualitative VDRL. So when we say quantitative VDRL naman, it simply refers to titration, dilution, and titration. So it is not actually quantitative per se, but more like estimation, quantitative estimation of the possible titer of your antibody. Okay, so the antigen used in VDRL are the following. So we have 0.03% cardiolipin, which is the main reacting component. Then we have 0.9% cholesterol, which enhances the reacting surface of your cardiolipin. And we have 0.21% lecithin. So please take note, actually lecithin, it can be 0.21% plus minus 0.01%, because there have been questions using 0.20 lecithin and 0.20% lecithin or 0.22% lecithin, and some students would actually consider that as a wrong statement because yun nga sabi nila it should be 0.21, but those are actually correct statement because lecithin can be 0.21% plus minus 0.01%. So the purpose of the lecithin is to remove the anti-complementary activity of cardiolipin. To prevent false positive results. Anti-complementary activity. Okay, to prevent false positive results. Okay, so for the reporting, of course, since it is a qualitative, if it's a quantitative, then we should report the titer. For the reporting of the qualitative, then we should just report it as non-reactive or reactive. We do not actually report, or we do not actually use the reporting term weakly reactive, because weakly reactive, you are just like saying doc 50-50, so now the physician will decide as to whether to treat the patient or not. And please take note that we are to use strong antibiotics in the management or in the treatment of, as part of the treatment of, rather, of syphilis. So when we say non-reactive, there should be no clumping observed, or no clumping or slight roughness that should be observed under the microscope. When we say weakly reactive, we can see small clumps, and for reactive, characterized by medium or large clumps. So, like what I said, since we do not report weakly reactive, what should we do if we see small clumps and based on our decision, it is weakly reactive? So neither positive nor negative. So for weakly reactive results, we should perform quantitative tests. before releasing VRDL results. So there should be verification as to whether it is a true positive or a true negative, or in this case, if it's true non-reactive or a true reactive result. So we should perform quantitative tests before releasing VRDL results. Okay, so let's now proceed to antigen delivery needles. So for qualitative serum VRDL, like what we have already mentioned during our discussion on the procedure, we should use an 18-gauge needle without bevel that will deliver 60 plus minus 2 drops of the antigen suspension per ml. So the needle should be held vertically. So please take note that during antigen delivery, the needle should be held vertically. Okay, then for quantitative serum VRDL, for the antigen delivery, we should use a 19-gauge needle that without bevel that will deliver 75 plus minus 2 drops of antigen suspension per ml. So that's for the antigen delivery. Then as for saline delivery, we should use a 23-gauge needle with or without bevel that will deliver 100 plus minus 2 drops of saline per ml. So as for your CSF VRDL, qualitative, this is qualitative we can use either 21 or 22 gauge needle that will deliver 100 plus minus 2 drops per ml. So take note that if the sample is CSF, we should rotate it at 180 RPM for 8 minutes. Okay, so that's all for your VRDL non-treponemal serologic test. So now let's proceed to your RPR.